I'm very happy to be speaking with you today. My name is Kassia Ellsworth, and I'm the Associate Director of Clinical Molecular Laboratory at the Rady Children's Institute for Genomic Medicine, also called RCIGM. Today, I would like to share with you our experience in implementing and scaling a rapid whole genome sequencing test at our institution. Rady Children's Institute for Genomic Medicine was founded as a nonprofit organization just several years ago, thanks to a very generous donation from a local San Diego benefactor. The institute is embedded within Rady Children's Hospital, the largest pediatric hospital in San Diego and the 6th largest children's hospital in the United States. The institute itself houses both the infrastructure and expertise to engineer novel genomic technologies and to manage the end-to-end sequencing process, from receipt of the blood sample to confirmation and reporting of genetic variants discovered through whole genome sequencing. We began genome sequencing in July 2016 and are currently a CLIA-certified, CAP-accredited clinical diagnostic laboratory. Our focus is on the intensive care unit in a pediatric setting, so NICU and PICU, where many of the sick children end up. This setting provides an opportunity to implement precision medicine and to have significant impact on the lives of children. The children with severe chronic illness account for only about 10% of the kids. However, that number accounts for about 70% of hospital costs. Thus, to understand this population of patients is crucial to not only benefit the patients themselves, but also for hospital economics. So our initial focus is in neonatal precision medicine is on the roughly 8,000 or so known genetic diseases that affect about 3% of children in the United States. There are different ways to cut these numbers, but on an average day in the United States, there are approximately 11,000 births. And of those, around 440 babies are born with one of these 8,000 genetic diseases. And roughly 64 unfortunately die before their first birthday. In the NICU and PICU, genetic diseases tend to be the leading cause of death. And the proportion of newborns surviving decreases the longer they are without diagnoses. Therefore, the earlier you get to diagnose these babies, you will likely see the biggest time span for benefit. So the earlier we get to these children, the better the outcomes. This is a model of the current standard of care process in the pediatric ICU setting. Currently, on average day in a children's hospital, about 4% of babies are acutely ill and transferred to regional NICUs, where the search for etiologic diagnoses begins. This is typically a 60-day cycle from interim empirical treatment, followed by either improvement or worsening of symptoms that may require treatment modifications. Oftentimes, the outcomes are either at-home discharge, sometimes palliative care, decisions, and unfortunately even death. This is how we envision the future of ICU care, where critically ill children are admitted to the hospital. And while a search for etiologic diagnoses and empirical treatments are underway, about 40% of these 4% of neonates admitted would be eligible for rapid whole genome sequencing. And based on the data from our various studies, we expect that a genetic diagnosis will be made in 20 to 50% of children tested, followed by a high percentage of those where the diagnosis will then inform precision treatment, leading to avoidance of mortality and long-term morbidity and shorter clinical stay with decreased hospital costs. Now let's take a step back and discuss why genome sequencing enables us to deliver results fast. There are technical advantages of utilizing the whole genome sequencing in the fast turnaround time setting, such as ICU. That includes faster laboratory workflow, such as library preparation time, then simultaneous detection of different type of mutations we are able to identify. For example, single nucleotide variants, copy number variants thanks to the uniform sequence coverage, and chromosomal abnormalities all at the same time. And of course, thanks to the fact that there's no PCR amplification required during library preparation, we reduce GC bias. Another important point to make is that there is a large and ever-increasing number of disease-associated genes, many with ambiguous phenotypes. This is a comparison of the number of genes from the Human Gene Mutation Database in 2017 on the top panel, and how significantly that number has increased just a year later in 2018. Lastly, there's a growing evidence of the benefit of genomic sequencing technologies, such as genome and exome, showing increase in diagnostic rates, as well as faster time to diagnoses. And this is just to show you the growing evidence in the literature. Before implementing the whole genome sequencing at the RCIGM enabled us to deliver the results in the timely manner. In the past year, our Children's Hospital implemented rapid whole genome sequencing within the NICU and PICU to test acutely ill babies and children. We have been able to return results on average 4 days from sample receipt to preliminary diagnoses, recently having performed testing within 19.5 hours. The current turnaround time for standard genetic testing that would possibly make the same genetics diagnoses is roughly 6 to 8 weeks. It's important to keep in mind the setting and the reason for the rapid whole genome sequencing, as stated earlier. Getting to these babies earlier has shown to greatly impact standard of care. So how does the RWGS process at our institution look like? Here's the overview of our process we perform today. We collaborate with more than 10 children's hospitals nationwide, where consent and enrollment takes place. At this time, we also receive patient phenotypic information. Once the sample is received and DNA isolated, the sequencing is performed on Illumina's NovaSeq. Next, the alignment and variant calling is being made for single nucleotide variants in indels via DRAGEN, and for copy number variants with DNA Nexus and our in-house developed pipeline. Then the combined VCF files are annotated in Fabric, where filtering, interpretation, and reporting takes place. Once report is generated, also in Fabric, that is being uploaded into electronic medical records. This workflow is clinically validated. Majority of the orthogonal testing or confirmations we perform in-house. We perform sequencing for internal as well as for the external patients. Since the initial implementation of the whole genome sequencing in 2016, we made several workflow changes that has helped us to improve the sample timeline and scale up this process. The major changes included changes in library preparation and performing sequencing on NovaSeq instruments. That helped us cut down the time by about 10 hours, which is a major improvement, especially for ultra-rapid sample timeline. Turnaround times are based on clinical urgency and volume and could be ultra-rapid, rapid, and standard. So now let's walk through the ultra-rapid workflow. Our turnaround times, as I just mentioned, are dictated by two major factors: laboratory capacity or volume, as well as clinical urgency. Internal as well as external samples can be designated for ultra-rapid processes. The patient's medical team requests the whole genome sequencing to be processed as ultra-rapid due to clinical urgency of their patient. This request is reviewed by the RCIGM clinical team. And next, our genetic counselors coordinate the response and feedback and reach out to the lab director team. Then the clinical operations team receives an email with the sample information, and then the laboratory process begins. How are we able to scale it up and process the samples in the ultra-rapid manner? Here are some key points. Sample will go from blood receipt to sequencing starting on the same day. Separate library preparation batches done if needed. Then samples that are tagged ultra-rapid go through the bioinformatics scheduler first once sequencing is completed. That simply means that the ultra-rapid samples are pushed ahead of other samples in the QE for further analyses. Also, upon accession of the ultra-rapid samples, an analyst is assigned to the case, so phenotyping of the sample is completed while sequencing takes place. So once the samples are ready to be analyzed, everything is in place. Also, the right tools to enhance the analysis process are needed. We use the Fabric Enterprise platform, where phenotypic prioritization of enter-HPO terms via VAST and fever-based algorithms helps with obtaining molecular diagnoses for the patient in a timely manner. Here's an example of roughly 108 cases with positive diagnoses with single nucleotide variants that were ranked by VAST fever in Fabric Enterprise. 83 out of 108 cases were with fever gene rank less than 10. 59 out of 108 cases were with fever gene rank as 1, and 71% of cases with fever gene rank less than 5. This graph to the right shows on the y-axis the fraction of SNV positive for molecular diagnoses with fever rank on the x-axis. Fever gene rank number broken for different studies we conducted at RCIGM are listed over here. But ultimately, it's the interpretation team effort to make the right call. Our multidisciplinary team is composed of 4 board-certified laboratory directors, 3 genetic counselors, 3 clinical genomic analysts, and 4 MDs with multiple subspecialties, and 4 MD fellows. And our team is still growing. We discuss the cases and assess the variants on a daily basis to make the molecular diagnoses and communicate the results with the ordering provider in a timely manner. Now I will switch gears, and over the next several slides, I would like to briefly discuss a couple cases to illustrate why our fast turnaround time process is important and how implementation of rapid whole genome sequencing in hospital ICU units show significant improvement in clinical care across different patient phenotypes. So the first case I will present will illustrate the power of rapid diagnoses via whole genome sequencing to guide treatment, and also limitations of standard laboratory and genetic testing compared to rapid whole genome sequencing. 8-day-old baby was admitted to the NICU with primary complaint of status epilepticus. The history was remarkable for prenatally detected fetal ventriculomegaly and poor appetite prior to onset of seizures. The EEG was performed showing burst suppression, and other abnormal findings included significant elevation of CSF lactic acid, as well as significant elevation in serum creatine kinase. Other studies were pretty unremarkable. Unfortunately, the disease progressed overnight, despite being on several different medications. The patient's physician discussed with the parents the range of outcomes he has seen with neonatal burst suppression, encephalopathy, which usually entails limited life expectancy and at least moderate to severe developmental disabilities. So this patient was nominated for ultra-rapid whole genome sequencing. It was proband-only analysis with parents available for additional testing if needed. Now, let me walk you through the analysis process we performed utilizing Fabric Enterprise platform. Once the case was created in this platform, we were able to start the analysis. We first start to look at the variants under the Select Variants tab. Here, we first select the HPO terms based on the patient's phenotype. In this case, the baby had seizures, it had ventriculomegaly, and poor appetite. We ran the query, which gave us a number of genes associated with the patient's phenotype. Ranking was performed by Fabric Fever algorithm, which combines multiple biomedical ontologies for accurate identification of disease-causing alleles. This enables quicker gene candidate association and a faster turnaround time, which again is important for these very critically ill babies. Two variants in the gene called ALDH7A1 were prioritized. We wanted to understand more about this gene's function, so we clicked on the gene name and quickly obtained various information about this top-ranked gene and the variant. The system provides a lot of information, including OMM entries for the gene disease association. In this case, indicated that ALDH7A1 is associated with pyridoxine-dependent epilepsy. Thanks to that, one can quickly assess if the phenotype associated with the gene overlaps with the patient's phenotype. There are many link outs to a number of different external databases to aid with the analysis and interpretation. Over here, we point to the OMM link. So we can quickly and directly go to the OMM database and gather more information for further gene and variant curation. The system also provides other information, including gene information, knowledge database, and what are the other variants that are present in this gene in this particular patient. As we move along, we wanted to understand more about the variant itself. First, we select the BAM link that enables us to go directly to the integrated genomic viewer from Broad Institute. And using this, we observe the buildup of the sequencing of data at this very location. You can see the sequencing looks pretty good, and this particular missense variant is present in the patient in the heterozygous state. Next, we were interested to see if there are any additional information and evidence for the classification of this variant in any databases. By clicking on one of the icons, in this case ClinVar, entries from ClinVar pop up, indicating variant ClinVar information regarding this particular change. And again, you can see that this variant was classified as pathogenic by multiple other laboratories. Again, the objective here was to gather all the information to classify our variant of interest in a timely manner. Based on the overall information that we gathered thus far, we felt that this variant in this gene was of interest, so we selected it for further curation and interpretation. Under the Interpretation tab, we curate variants, first by selecting variants with a particular disease, here specifically with pyridoxine-dependent epilepsy. Next, we select what evidence we have for the variant by answering questions based on the ACMG guidelines. These answers are then aggregated within the system to establish variant classification, which in our case classified the variant as pathogenic. Under the Interpretation tab, we also fill out the variant description based on all the information that we were able to gather about the variant and the gene, and that description will go onto the final report. In this case, two pathogenic variants were selected for reporting in the LDH7A1 gene, and both of them are present in this table. The description of these variants that we were able to input under our interpretation variant tab now is present on the report as well. Then we finalized the report, and we worked closely with Fabric to create our own templates for reporting, example of which you can see on this slide. So in summary, this patient was identified to have two pathogenic variants in LDH7A1 gene associated with autosomal recessive pyridoxine-dependent epilepsy. We were able to reach this diagnosis in 55 hours after patient consent. We issue a preliminary report because there is a precise treatment for this condition. It's vitamin B6, also known as pyridoxine supplementation. So once the results were communicated to the ordering physician, the triple therapy with pyridoxine, L-arginine supplementation, and dietary lysine restrictions was initiated. His EEG normalized and seizures stopped. Soon after, he was discharged home, and at current moment, he's meeting the milestones at 11 months of age. And this particular family is pictured over here with Dr. Kingsmore, and this is our patient. Neonatal seizures have broad differential diagnoses, but subset of them have genetic etiology. There are over 850 genetic causes of seizures, and many of them have specific treatment. So the sooner we are able to get to diagnoses, especially for ones with described effective treatment, the better the outcomes are of the patient. Next few slides illustrate just that. There was another baby that came into the NICU at 1 day of age with tonic and myoclonic seizures. She was treated with anti-seizure medication to no avail. That's when the rapid whole genome sequencing was indicated. Here's the full evolution of this particular case. With the new genomic sequencing technologies, this analysis probably would be even faster. But let's take a look. Day 1, the family consented and enrolled into our study. On day 2 and 3, the DNA was isolated, the library was prepped, and sequencing started. On day 4, genome analysis and interpretation takes place. Day 5, molecular diagnoses enable change of medication targeted to genetic problem. Day 18, she's home 12 days after diagnosis. So 18 days after the admission, she was home in time for her family Christmas. But how does it compare to the standard genomic testing? Let's find out. Before RWGS was available, we had a patient with the same symptoms. She was also admitted to our NICU. The time to diagnosis with standard genetic testing was 6 weeks. The standard genetic testing in this case identified pathogenic variant in the same gene as in the case of RWGS, but the outcome of that child was very different. Baby with extended exposure to uncontrolled seizures was neurologically devastated. So time does matter. 6 weeks with standard testing versus 6 days with rapid whole genome sequencing, and the outcome was very different. So next case illustrates a clinical utility of a rapid whole genome diagnosis. This is a case of a 5-week-old baby that presented to the emergency department with rapid breathing and cyanosis. The baby was admitted to the cardiac unit in cardiogenic shock and respiratory failure. The baby was found to be in acute decompensated heart failure due to dilated cardiomyopathy of uncertain etiology. The baby was on the ventilator due to acute respiratory failure. This child was admitted to the NICU on day 1. That's when the sample was collected. Day 2, sample was received at RCIGM, DNA extracted, and library prep started. On day 3, sequencing took place, and day 4, once sequencing was completed, all the downstream processes took place, including notifying the ordering provider with provisional diagnoses. This sample case from sample receipt to provisional results was reported in about 50 hours. To analyze this case, we again use Fabric Enterprise platform. We entered the HPO terms that were consistent with the patient's phenotype for fever ranking. Fever ranked as number 1 two variants in the gene called ENPP1. ENPP1 is the gene that encodes for an enzyme that breaks down ATP to AMP in pyrophosphate. Pyrophosphate prevents abnormal deposits of calcium or calcification in the body. The pathogenic variation in this gene is associated with arterial calcification, generalized of infancy, and average survival of these children is less than 6 months. However, majority are diagnosed postmortem. Importantly, per gene reviews, use of biphosphonates appears to significantly increase survival. So this patient, given diagnosis so early, was started the treatment and was then discharged home. Most importantly, this patient avoided heart transplant. So this is the patient that was diagnosed with this specific condition. And he appeared on actually news channel in back in Minnesota. In our experience at the Institute thus far, we performed sequencing on more than 760 patients across multiple studies. 37% received a definitive genetic diagnosis. And out of those patients, 70% had a change in medical management. Medical management included new medication or initiation of new medication, screen for multi-system involvements, as well as inform palliative care decisions. However, we need to remember to interpret diagnostic numbers with caution, as depending on the study and its inclusion criteria, the diagnostic rate did vary. For our NICU randomized clinical trial study, the genetic diagnosis rate was about 25% because of the very broad inclusion criteria of this patient in our study. For example, patients that come from external sites, the diagnostic rate is much higher, which is about 45%. When we examine the phenotypes of patients tested at RCIGM, an external partner hospital system across the US, the range was very diverse. The most common phenotypes and presentations included neurological presentations such as seizures and encephalopathy, congenital heart defects such as abnormal heart morphology and arrhythmias, as well as inborn error of metabolism. So with one whole genome sequencing test, we obtained a multitude of diagnoses. And this is just an example with genes highlighted in green indicating multiple diagnoses that we are able to obtain for the patients. The power of genomic methodologies is that they address not only heterogeneity in diagnoses, but simultaneously ascertain different type of variants, as we not only identify single nucleotide variants and indels, but also copy number variants or a combination of those two. Just to illustrate the different type of variants we identify, Here, the pathogenic compound heterozygous variants identified in SCYL1 gene. One is a nonsense change, and one is a 170 kilobase deletion that were detected in a patient with spinocerebellar ataxia, a known phenotype associated with pathogenic variation in this particular gene. So now let's switch gears a little bit. Thus far, we went over why we implement the rapid whole genome sequencing and how do we do that. Now let's see what does the rapid whole genome sequencing test mean for the providers and the parents. As the providers and the parents are the stakeholders, and partnering with stakeholders is essential for precision medicine implementation and to make this test a routine standard of care. We asked the ICU doctors, is the rapid genome sequencing useful? Most found the test to be useful when the patient did as well as did not receive diagnoses. We also asked parents, did the test, did they understand the genomic sequencing results? Majority of the parents said yes. We also asked the parents, was the test useful? Again, the parents also said that when they did and when they did not receive genetic diagnoses, the test was useful. We have partnered with a number of hospital, NICU, and PICU systems across the United States for implementation of rapid whole genome sequencing to enhance access to genomic services and build the evidence base to justify it. The hope is that as we continue to build and collect the utility and cost effectiveness data, implementation of this test will become even more widespread. So what are our future plans? Of course, we need to go faster. There are several ways we can still decrease our sample timeline, which include evaluation of new technologies to increase speed, evaluation of supporting technologies, clinical natural language processor, which is automated translation from EMR to HBO terms, and advances in algorithms and artificial intelligence will aid to drop interpretation time. However, to continue to make this test faster and available to all the patients that need it, we need collaborative efforts from everyone that is involved in this process. In summary, here are some of the challenges that we face. Is this expense of the whole genome sequencing justified? We, among other groups, are currently working on more data to assess that, but I show you a few of the examples that definitely the expense was justified. We are reviewing, what about the genomic analysis time? We are reviewing automated variant prioritization approaches and artificial intelligence tools in order to improve it. There are known limitations of genomic sequencing approaches, some such as polynucleotide repeat, we can actually assess with whole genome sequencing, which again, we are currently evaluating. With performing genomic sequencing, responsible consent and return of results is very important. So solution is education and outreach, as well as collaboration with genetic services. Decision support for molecular diagnoses. Again, solution to that is to educate and to outreach to medical providers, as well as medical fellow training. And finally, the summary, early studies have shown the benefits of rapid genomic sequencing testing to reduce patient suffering and provide hope to families, to end diagnostic odysseys by speeding answers to medical mysteries, and to reduce length of hospital stays and costs. Whole genome sequencing can guide medical management of genetic diseases, example of which I gave with few case examples that I presented today. More evidence is needed to make rapid whole genome sequencing a first-year test in the NICU and PICU, so collaboration among various groups involved in the process is truly crucial. And with that, we hope that the most acutely ill newborns and children have access to this test as routine standard of care. With that, I would like to thank everyone at the Institute, as well as our collaborators and the patients. It truly takes a village to make this happen. So thank you to all.
Kassia, thanks so much for your compelling presentation on your work, as well as the impact that you folks at Rady are having on patient outcomes. What I want to do for a few minutes is share a little bit about the Fabric Enterprise platform. So NGS has really revolutionized genomics, but the critical bottleneck has shifted from the production of data from the sequencer to really making sense of that data in the interpretation. And historically, it has been difficult, time-consuming, and especially labor-intensive to translate that raw sequence data into useful and reliable information that can be used in the clinic. And so this is the problem that Fabric has focused on, and we are at the forefront of really automating and scaling the interpretation of data to diagnose patients. What we deliver is an end-to-end platform for genomic data analysis. So basically taking that raw data off of the sequencer, either as a FASTQ file, and running it through the secondary analysis. We can also pick up a VCF file that has been produced upstream and then take it through interpretation and output a clinical report either as a PDF or a structured output via our API. So talking about the technology that enables this platform, as Kassia showed with Rady's analysis of 108 cases, VAST and Seizures, Fabric's proprietary variant ranking algorithms, enable consistent and accurate identification of disease-causing variants. Our AI approach also significantly reduces interpretation time, and this enables labs to significantly scale whole exome and whole genome testing. These two algorithms were co-developed through our longtime collaboration with Mark Yandel's lab at the University of Utah. So on today's webinar, we have been focused on the use case of whole genome testing. Fabric's platform supports whole genome as well as whole exome interpretation for rare disease as well as diagnostic odysseys. And we support panel testing for both hereditary and somatic use cases. Indeed, Fabric can be used for a broad set of medical conditions, including hereditary cancer, cardiovascular disease, neurological conditions, carrier and newborn testing, pediatrics, and population health. Building on Fabric's strong AI and bioinformatics capabilities, we're excited to announce that we're launching a new AI engine for variant classification. And this is coming out in just a couple weeks in early April. This new engine accelerates robust classification of variants in a fashion that is compliant with ACMG standards. We're very excited about our validation results and look forward to sharing more of this at ACMG. And to that end, please come and meet us at the ACMG annual meeting from April 2 to 6. We will be in booth 923. We are also a sponsor of Rady's Frontiers in Pediatric Medicine conference that Kassia talked about at the beginning of May. More information on both of these conferences is at our website, and we look forward to connecting with you. And with that, I will hand it to Jared for questions.
Great. Thank you, Kassia and Charlene. We do have a number of questions that I'll go through. Start now. How many team members does it take to go through the overall pipeline?
So our team is composed, I guess, of different modules. We have a laboratory-based team where we have a laboratory-specific laboratory director, as well as 5 CLS members of that team that handle the sample accession, DNA extraction, library preparation, etc. Then we have a team of bioinformaticians that basically make all of the processes downstream from the actual sequencing possible. And then, as I mentioned in my talk, we have several members of the team that focus on the interpretation. So there's many individuals involved in the process. I'm not even mentioning the individuals that really are strongly involved in patient enrollment and communication with the physicians directly prior to even obtaining the sample specimen.
Thank you. Do you do trio analysis sometimes? And if so, can Fabric's pipeline handle that?
Yes, definitely. In my examples today, I did not show that. However, certainly we do singletons and trios, and Fabric does a wonderful job in handling that. And we have different filters established in order to see, for example, de novo changes that we as well are very interested in knowing. So yes, Fabric does handle trios, and we perform trio analyses as well.
Great, thank you.
And this is Charlene. Just to add to that, within the Fabric platform, we can support multiple types of family-based analysis. So as Kassia mentioned, we can support solos as well as trios. We can also run analyses where it's a duo, so just a single parent or additional family member. And we can also support family configurations that go beyond trios. So if there is an additional sibling, or if there's a sibling who you want to include in the analysis, or an extended member of the family.
Great, thanks. Why did you choose blood samples rather than saliva? Is it less invasive for the kids, maybe?
Yes, so blood samples, obviously it's some type of specimen that a lot of times these children already are drawn samples for other studies. So getting additional sample in order to perform the analysis for DNA extraction, for the most part, it's pretty straightforward. But yes, we are currently validated to perform saliva testing on the parents and the children. That's not always possible for the little babies to obtain that specimen. However, we are not validated to perform whole genome sequencing on saliva DNA as of yet. But that's something that we're currently working on.
Thanks. Is the rapid whole genome sequencing protocol published?
I think we're currently working on that publication, and definitely will make it available to people down the road. Mm-hmm.
Great. Here's a question: is there any pediatric research at your organization?
Oh, absolutely. So we are a research institute. We perform a lot of clinical research here, and we have actually multiple researchers that are associated, so are part of the institute or part of the collaboration efforts. We publish already several papers regarding what's going on here based on the patient cohorts that we have. So this is an ongoing project. Yes, different type of research is being performed at our institution.
Okay, great. There's a number of questions about whole exome versus whole genome sequencing. Can you talk about that decision
Oh, sure, sure. Because I mentioned during my talk that we had a randomized control clinical trial. That objective of that trial was to basically compare whole exome versus whole genome sequencing, and analysis of the data is ongoing as we speak. However, we need to remember the setting that we operate in. We mostly sequence children in the intensive care units, where fast diagnosis is crucial in order to make a difference for those patients. With whole genome sequencing, we basically can get to many diagnoses with one test much faster, especially if this test is done in the rapid manner. However, as we know, whole exome sequencing and whole genome sequencing testing can get to many diagnoses at the same rate. The difference is, I guess, the turnaround time, how fast we perform this type of testing here at our institute, as well as some technicalities in terms of what additional information we can obtain with one test, which is genome, as opposed to whole exome.
Thank you. Next one, there's multiple people asking about CNVs. So how does CNV analysis compare to clinical CMA?
There's actually multiple publications in the literature present, so I'll refer to that. But we also know that rapid whole genome genome sequencing as a test definitely can detect all the copy number variants. I would say this test is more sensitive in the sense that we see small as well as large deletions and duplications. So I hope that answered the question.
Great. In your, what is your % of diagnoses that are due to CNV?
Due to the CNV?
Yes.
Oh, that's a very good question. To be honest, we are working on kind of doing this type of analysis, how many cases we have that was due to the CNV versus a mix of SNVs and copy number variants, as basically compound heterozygous changes in some of the patients. We have several examples of those. However, it's hard for me to tell you the exact percentages that was solely due to the copy number variants at this time.
Great. Any further research for that 63% of undiagnosed cases?
Yes, given that we have the whole genome sequencing data available for those individuals, once we learn more about the genome, the intronic regions of the genome, and the new tools will be available, the reanalysis will probably take place. At the same time, a lot of patients were enrolled under some research protocols. Therefore, this data is being reanalyzed as well. So.
Great. And then does Fabric support CNV classification?
Copy number variants classification is being supported by Fabric in a way that we have access to different databases. We can see the previous classification of those events that we done here in our institution. Basically that enables us to classify that based on what information we can gather for the variant itself.
Great. How do you handle reanalysis for negative cases, laboratory workflow wise or in the Fabric visualization tool?
That's a great question. I think a lot of different laboratories are currently struggling with it unless they have already established policy regarding reanalysis. We are actually trying to come up with the policy regarding this matter. And we start to look at different things. First one is, when to perform the reanalyses. Here we deal with the very unique population of patients. A lot of times we sequence babies, in the NICU setting. Therefore, reanalyses can be done based on the change in the phenotypes. These babies' phenotypes can evolve over time, very short periods of times, not years, as opposed to older kids that we sequence. Also, another thing is that, is there a way for us to do it in automatic way? And we're currently evaluating other ways or tools in order to enable enable us to do this in a timely manner as well.
Great. How do you decide whether there is a positive mutation hit? Is it based on a score threshold, or how do you validate the discovery?
So basically in our process of evaluating the genome in Fabric, I mentioned that we do rely on the fever scoring, which is pretty outstanding tool and does help us to make this diagnosis in a timely manner. However, we have several filters that we establish, and when we do that for every single case. So it's not only looking at the very first few hits that we see, but basically going through the case in a very systematic way, and assessing the variants in terms of whether or not, they fit the phenotype, but also whether or not they were reported previously, whether or not, they score based on the in silico scoring as damaging, and browsing the literature for that manner. I think this is pretty a standard process for many clinical labs, so we just do that.
So someone comments, "This is a great talk. Can you tell us what type of mutations are detected outside the Dragon pipeline? Are you using an in-house workflow to detect SVs and chromosomal rearrangements?"
So basically we use the DNA nexus in order to help us with looking at the larger events such as copy number variants. And I'm not sure if that was the question. Sorry, I don't see it in front of me. So so that basically just enables us to see those larger events. And then the VCF files are combined and then annotated in Fabric for downstream processes.
As a research platform, are parents given findings beyond ACMG 59?
So we at the Institute specifically do not focus on the ACMG 59 secondary findings. However, when we enroll the family or the proband or the patient's parents, we definitely consent to incidental findings. If we come across an incidental finding and the family wish to know about it, as long as the scores is pathogenic, and there's a management associated with potentially knowing about this finding, then the family is informed about it.
Okay. And then along with that consent, do you reconsent kids at age 18 to keep their data and samples?
Depending on the protocol, the patients are enrolled, and whether or not there's age limit, then yes, they will be re-enrolled into the study if they wish to be re-enrolled. Otherwise, the data is being de-identified.
Great. Are CNVs confirmed using an orthogonal method before reporting?
Yes, that's a very good question. So all the variants that we report are confirmed on the final report. And yes, we have a specific pipeline and in-house platforms in order to help us with confirmations for SNVs as well as for copy number variants.
Okay. Do you have plans to evaluate other assays, RNA-seq or long reads?
Not at this current moment. We actually truly want to focus on whole genome sequencing and making the whole genome sequencing test better. We know that there's still a lot to be done and a lot of information that we can get from whole genome sequencing tests as we have it right now. So we collaborating with other partners to basically see where we can get with that.
All right, great. Are there, and then I think this is the last question that we can do with this time. Are there any incidental findings within the ACMG 59 gene list or any gene with clinical manifestation in infancy?
That's a very good question. I cannot think about it at this current moment. So speaking about the secondary findings and ACMG 59, we kind of see that a little bit differently in terms of whether or not somebody has potentially there's any intervention for the future versus whether or not we can do something at the current moment. Because if the patient comes in the seizure and that's the primary phenotype, and we identified a genomic syndrome of the patient that is associated with let's say intellectual disability, that basically is an incidental finding for the family. So they did not come in to look for a answer to future being at risk of developing intellectual disability. They came in for looking for the cause of the seizures. So this is something that we definitely do discuss with the family prior to testing. And if they wish to know about any incidental findings, as long as they are scoring as pathogenic, that information is being given to the family.
Great, thank you very much. So gang, that's all the time we have for questions. Unfortunately, we got through a lot of them and there's a lot more. If your question wasn't answered, we'll respond directly to you. If you'd like more information, you can email Charlene directly at her email on the screen. And I'd like to remind you, multiple people were asking about this, but this webinar is recorded and will be available for on-demand viewing in a few days. I'd like to thank Kassia and Charlene for presenting today, and I thank you all for joining as well.